Inside a pressurized, infected tissue cavity, percutaneous drainage relies on the sudden, violent uncoiling of a rigid plastic catheter. Placing a drainage tube constitutes a complex exercise in mechanical plumbing, extending far beyond the logic of a simple diagnostic needle stick. The margin for error is measured in millimeters and fluid viscosity. Miscalculating the fluid dynamics or the local anatomy will aggressively force a localized infection directly into the patient's bloodstream. Successfully clearing a collection requires precise catheter mechanics, rigid anatomical routing constraints, and algorithmic troubleshooting after placement. Treating an abscess means taking a chaotic, life-threatening biological crisis and forcing it into a predictable, manageable mechanical process. The first step in the algorithm is gaining mechanical access to the collection. Operators rely on two established entry techniques. The trocar method is a direct tandem approach. A spinal needle is placed into the target first. Then, immediately adjacent to that needle, a catheter is forced directly into the cavity. The Suldinger method is sequential. A single needle stick achieves access. A thin guide wire is advanced through the needle, the tract is progressively dilated over the wire, and the final catheter is placed along that established track. Once access is achieved, the physical viscosity of the fluid dictates the necessary diameter of the tube. This sliding scale maps fluid density to catheter size, measured in French, a unit where 1 French equals exactly 1/3 of a millimeter. At the low end, clear, non-viscous fluid strictly requires a small 6 to 8 French tube. As resistance increases, the diameter must expand. Thin pus requires an 8 to 10 French cross-section. Thick, mature pus mandates a 10 to 12 French tube to maintain continuous flow. At the maximum extreme, collections filled with necrotic tissue and heavy debris, like diverticular abscesses, require 12 French or larger to physically pass the solid material. Even with perfect sizing, a common clinical trap occurs at the bedside when care teams attach a 3-way stopcock to the end of a large 12 French drain. Cautionary: the internal valve of a standard stopcock is highly restrictive. Routing thick fluid through it artificially chokes the functional lumen down to 6 French. Matching tube size to fluid viscosity achieves nothing if downstream hardware creates a mechanical bottleneck. The physics guarantee drainage failure. Shifting focus to the pelvis introduces a geographic problem. Gravity forces infected fluid to pool in the deepest, most posterior anatomical spaces. Reaching these spaces requires navigating 4 absolute routing rules. Choose the shortest path, avoid vessels and nerves, do not cross sterile anatomical compartments, and ensure the tube rests in a dependent position, the lowest point where fluid naturally collects. The transabdominal route appears intuitive, but a long anterior approach to a posterior collection violates the dependent position rule, leaving stagnant fluid behind. If the transabdominal route is utilized, operators must avoid accidentally puncturing the inferior epigastric arteries during trocar gracement. To access posterior targets effectively, the transgluteal route is the primary solution. This requires the patient to be placed prone under CT guidance. Transgluteal access carries a strict anatomical safe zone. The needle must pass directly through the sacrospinous ligament. Within that ligament, operators face 2 rigid directional constraints. The trajectory must remain as medial as possible and strictly inferior to the piriformis muscle to avoid severing the sciatic nerve or the gluteal artery. Percutaneous skin access can be entirely bypassed by using endoluminal routes, specifically the transvaginal or transrectal approaches. Endoluminal access satisfies the 4 routing rules by providing a radiation-free shortcut through natural orifices directly into the dependent presacral spaces. These routes carry a fatal mechanical flaw. Natural body movement creates severe catheter instability, often expelling the tubes entirely within 3 to 4 days. Pelvic drainage is an exercise in negotiation. Operators must balance a perfect dependent angle against the rigid reality of surrounding nerves and vessels. Once the tube is secured, the procedure enters the post-placement management phase. This is where flawed medical instincts cause the most fatal errors. A common error is the culture trap, withholding empiric antibiotics until pure fluid cultures are pulled from the newly placed drain. Forcing a drain into an abscess ruptures capillaries, violently seeding the bloodstream with bacteria. Without immediate antibiotics, this mechanically accelerates the patient into life-threatening sepsis. At the bedside, the physical management of the tube is often mishandled due to confusion between flushing and irrigating. Flushing is the injection of a low-volume fluid strictly to maintain tube patency. It clears viscous blockages located inside the plastic lumen itself. Irrigation is entirely different. It uses high-volume fluid to actively wash out the entire biological cavity surrounding the tube. Consider the dangerous math of aggressive irrigation. If you inject 20 cc or cubic centimeters of fluid into a cavity, but you only aspirate 5 cc back, you have a trapped volume crisis. Trapped fluid mixes with the infection. Hydrostatic pressure expands the cavity walls, violently pushing contaminated liquid into adjacent sterile tissues, creating new pockets of infection. When a catheter stops draining entirely, the algorithm dictates specific steps. First, obtain imaging to confirm the tube has not migrated or formed a mechanical kink. If the tube is unkinked, operators attempt to clear the clog with a flush or a guide wire. If the blockage is solid and the tissue tract has matured, the immediate solution is to remove the tube and upsize to a wider diameter. A perfectly executed physical insertion can be instantly undone if the post-operative fluid hydrodynamics are mismanaged. Beyond general fluid dynamics, specific organs introduce instantaneous hazards that require immediate deviations from the standard algorithm. In the pancreas, uninfected necrotizing pancreatitis must never be drained. Placing a tube into sterile dead tissue mechanically introduces external bacteria, guaranteeing a lethal infection. If fluid pulled from the pancreatic region is clear instead of brown, it is raw pancreatic fluid. Prolonged drainage of this clear fluid creates a persistent cutaneous fistula, an abnormal pathway leaking digestive enzymes out of the body. In the liver, the trajectory targeting an hepatic abscess must never cross the pleural space of the lungs. Doing so pulls the infection upward, causing an empyema, a severe collection of pus in the chest cavity. Before biopsying or draining a suspected liver abscess, echinocal cysts must be ruled out. Aspirating a parasite-filled echinocal cyst can trigger sudden, lethal anaphylaxis. In the kidneys, small perinephric abscesses respond effectively to intravenous antibiotics. Mechanical drainage is reserved for collections that exceed 3 to 5 centimeters in diameter. For post-transplant renal fluid collections, aspiration is required to check the creatinine level. If the level matches the patient's serum, it is a localized lymphocele. If it is significantly higher, it is an active urinoma leaking from the renal system. Organ geography determines the routing strategy and identifies cases where mechanical intervention must be abandoned entirely. The final phase of the drainage algorithm relies on strictly defining the criteria for safe catheter removal. Over a period of several days, the normal physiological expectation is that fluid output will steadily and predictably taper toward zero. Safe removal requires these 3 strict conditions. Daily drainage must drop below 10 cc. Cross-sectional imaging must confirm the tissue cavity has collapsed, and there must be no evidence of an ongoing fistula. This graph illustrates daily volume over time. The ultimate warning of failure is a sudden spike. This surge means the infection eroded through the cavity wall into a neighboring structure, forming an active fistula, an abnormal connection, with the bowel, biliary tree, or urinary tract. When a volume spike occurs, removal plans are immediately halted. The next step is strictly to obtain fluoroscopic imaging to mechanically map the new anatomical leak. Safe percutaneous drainage requires the simultaneous management of plumbing mechanics, pelvic anatomy, and the mathematical indicators of fluid failure.